Good evening. Oh, too close. I'm Bertha Cooper, a member of the League of Women Voters of Clallam County, and I will be your moderator this evening. The League welcomes you to the first of 4 important forums on the urgent need for broad healthcare reform. We are pleased to share this sponsorship with Olympic Medical Center. We also wanted to thank Peninsula College for giving us this venue for our forums. The League of Women Voters is a national organization of which Clallam County is a branch. We are a nonpartisan, nonprofit organization. Our focus is on issues which affect all people, regardless of political persuasion. Issues such as water, environment, education, and healthcare. We also present election forums with political debate between candidates and ballot initiatives so that people can be informed voters. Start looking for announcements of those forums soon. Conducting forums like this is one of the ways the League encourages informed and active participation in government. Your participation here tonight helps us carry out our mission. We thank you all for coming, and we're happy to see so many of you here. I hope you picked up a program on your way in. If you didn't and want one, just raise your hand and we'll be sure you get one. You also should have gotten a small card on which you can take notes or formulate questions to bring to the open mic for our question and answer period. We want you to know that we're recording the program portion, not the open mic, but the program portion, because we want to be able to bring this information to other venues in the community. Our rules are simple. We ask you to turn off all electronic devices that could interrupt the forum. We time our speakers. We give them the courtesy of alerting them when they're close to the end of their time. The forum will end at 9 o'clock. At the completion of the program or the speakers, we will have questions at an open mic. There are no long breaks planned, so feel free to get up, stretch, leave the room if you need to at any time. The League takes no position on the statements made by the speakers other than we think it's important to listen to their message and decide the importance to you. However, in the interest of disclosure, we want you to know that the League has developed position statements in some areas and not in others. In the case of health care, the Clallam County League has a position on health care reform, which is to support single-payer system. The League's website has been included on your program, or if you want to pick up a copy of the position statement, it's at the desk. But we're not here tonight or during the remaining 3 forums to discuss single payer. In fact, we will only discuss alternatives to our current system in our final forum, and then we will cover an array of possibilities. Rather, our intent is to give you information, to inform and to involve you in becoming a voice for the need for broad healthcare reform. The voice will be yours, and whatever point of view you develop. We believe that our policymakers will respond to voices, loud voices, that expect them to do the hard work of reform. I will take a minute to describe each one of our forums, which are critical to understanding the dysfunction of our current system. We hope your interest will grow and you will attend all of the forums and invite others that may have an interest. Tonight, our intention is to set the stage, the sense of urgency, by describing the impact of our current system on individuals, local services, national economy, and national health outcomes. Our second forum is around coming to terms with the ethical, moral questions such as, is healthcare a privilege to be earned, are a right, regardless of individual responsibility. We expect to hold that forum in late June. The third forum will present the complexity of healthcare in our country as a service and as a market. There are multiple and varied incentives within the existing structure that are often at odds with each other. Finally, the fourth forum will discuss solutions. At this time, I will announce that Dr. Tom Locke needed to withdraw from participation last weekend. He has a very ill family member that he needed to attend. Our thoughts are with him and his family. Dr. Chen expanded his presentation to include health outcomes on very short notice. Thank you. Tonight's forum is Why the Urgency? Why are we making a case for broad healthcare reform? What's not working? What are the personal stories in our community? What's the impact on our local services, Olympic Medical Center? What's the impact on the national economy? And what's the impact on health outcomes? I am going to shift my role now as moderator to speaker and warm-up act. I will start by highlighting factors important to understanding the dynamics of health in our country and why the need for bold and broad reform. You will hear these themes and more throughout the program. I'll set the stage. The average annual cost of health care insurance for a family of four is $20,000 a year. I looked up county data, our county, Clallam County, and found that for a household of 2.3 people, that was as close as I could get to 4, the median income is a little over $42,000. 50 million Americans are uninsured. That represents an increase over the last 10 years of over 3%. Healthcare inflation rose by 48% from 2000 to year 2010. The Consumer Price Index rose 26%. 50 years ago, healthcare was 5% of the gross domestic product. In 2010, it was 18%. 1 in 7 American jobs are in healthcare. Most people, if not everyone, agree that healthcare costs too much, and it's unsustainable. Now, there's reason for that cost, some of which are quite positive. There have been amazing technological advancements. We have machines that can look inside of us and see what's going on, what's working, what's not working, and then we have machines that can go into our bodies and fix them, like robotic surgery or linear accelerators, but it's expensive and it changes frequently. In 2011, Olympic Medical Center put a new state-of-the-art linear accelerator in the cancer center at a cost of nearly $3 million. The last time they did that was in 2003 when they put in a state-of-the-art linear accelerator at the cost of $1.8 million. So the technology improves, the costs go up for a variety of reasons, but it's brought exceptional care and ability to our system. Another important reason that costs are increasing is that chronic disease and its care is increasing. Diabetes type 2 is on a steady increase over the years. Sadly, and maybe shamefully, the disease is also developing more in younger people. It's a disease with a person can live for years, live with for years, but it costs money to manage and maintain. It costs more because we're ambivalent about cutting off care to people. Many people see that or hear that as rationing, and most of us can recall the great fear that was expressed that there would be so-called death panels to deny care. A lot of political finger-pointing and paralysis. We're not looking inside our own system. We're sticking with outdated structures such as fee-for-service and not focusing on structures for prevention. We seem to be more focusing on reducing costs by reducing access. After all, if you don't get care, it doesn't cost. Part of that's driven by the high cost of care and the high cost of insurance. It's simply unaffordable for some people. Individuals and families are paying more out of their taxable income for health care. There's more co-payments, there's more percentage of premiums that they're paying, and there are higher deductibles. Businesses are reducing coverage, are providing catastrophic only, or maybe not providing it at all. There's a lot of talk about increasing the age of Medicare eligibility, which of course has the effect of denying access to reduce cost. We've been dealing for a long time with denying coverage for certain or pre-existing conditions. I've never quite understood how we would have programs that would deny care to the very people that need it. But that goes on, and we've heard a lot of stories, and we'll hear more about that tonight. The favorite way is to reduce payment to providers. That's been going on for years, hasn't it? You've been reducing payment to providers. We're getting close to the bone on that. I think the best example are physicians who, for a few years now, have been saying, I will only take a certain number of Medicare patients. I can't afford to have a full caseload of Medicare patients. There are some physicians that won't take Medicare patients or Medicaid patients. There are some physicians that will charge an additional fee or a monthly fee to all of their patients. They're known as concierge doctors in order to build a caseload that they can really afford for their own practices. 100 years ago, this was healthcare. Black bag, doctor, a doctor in his bag, and it probably was a his. You went to your doctor's office or your doctor came to your home. You may have gone to the hospital, but you probably didn't want to because that's where people went and died. And they probably did. Very simple. And you paid your doctor. You gave him dollars, or you gave him chickens, or you gave him vegetables from your garden, but you paid your doctor for the services. Very simple. Not so simple nowadays. The Social Security Act of 1965 created Medicare and Medicaid. Insurance for the elderly, insurance for the disabled, insurance for the poor, especially children. That started something big in healthcare. There's a mechanism for taxing and spending, a mechanism that put dollars into healthcare. Medicare designed a delivery system. It said you no longer have to get or need to get all your care in a hospital. You can even get some care at home, more appropriately at a lesser cost. Going to skilled nursing facilities or getting care in rehabilitation centers instead of hospitals. New services, new industries, more research began to come into healthcare. And we saw the beginnings of a healthcare market. We saw enormous service development and expansion. We saw product development and expansion. We saw innovation, entrepreneurs. A lot of that technology came out of this. For-profits, not-for-profits, publicly traded companies, all joining into healthcare. And the phrase free market competition was introduced into healthcare. And you hear a lot about, if you listen to discourse today, about free market competition. Also about regulation. Regulation to control costs, regulations to control fraud and abuse, regulations for quality, safety, and outcomes. It's an enormous regulatory burden on healthcare as a result of these factors. Now, we have a very complicated system, sometimes integrated, sometimes fragmented, but very good and does some things the very best that can be done in the world. We have technology in record keeping, we have technology in diagnosis, we have technology in treatment, we have specialties in medicine. We have a very complicated system. And we're living longer. In 1912, the life expectancy for a man was 48 years. In 1912, for a woman, it was 52 years. Today, life expectancy for a man is 76 years, and for a woman, 81 years. Now, that's not all due to healthcare, but that sure helps. Some of that is due, a lot of credit has to go to public health. Public health that eradicated deadly communicable diseases like smallpox and polio, and today, influenza. So we're not exposed as much to those things. Following World War II, there was a better standard of living, better housing, better nutrition. Some people would say too much nutrition. But we're healthier. We are healthier. We're living longer. Are not. More of us are living with or dying from chronic disease. The United States ranks 34th in international ranking of life expectancy in 2011. And you'll see from my notes that in 2007, we ranked 29th. 2010, we ranked 33rd. Seems like the wrong direction, doesn't it? Now, it may not be that we're getting so much worse. Maybe everyone else is just getting so much better. But it's worth looking at. I'm sure Dr. Chin's going to talk about this later. Let's talk for a moment about what we're not looking at in our system, some of the things that we should be asking our legislatures to look at and think about changing. One is that there's a great disconnect now between the patient and the provider in terms of money. No more chickens and dollars to the doctor. It's now an insurance card. After World War II, healthcare became a benefit. That was mainly because there was a wage freeze and they wanted to pay in some way, employers wanted to pay in some way. Well, that's become a standard now, and we are often referred to as an employer-based insurance system. That works really well if your employer provides insurance, but what if they don't? We pay providers under a fee-for-service arrangement. There are some exceptions to that, like group health and some of the Medicare Advantage plan, but pretty much it's fee-for-service. Doctors, the professional incentive for a physician is to heal. The financial incentive under our system for a physician is to make more visits. or give more service. The commodity is a visit, that hospital visit or that office visit. Hence, we hear, or maybe we've experienced, the 10-minute doctor visit. We reward diagnosis and treatment, which is good. I want diagnosis, I want treatment if I'm sick. But we are not rewarding prevention. We're not looking at how do we prevent diabetes, because prevention would be a lot less costly than treating people with the disease. But in fact, funding for public health has been declining over the years. We're over-testing as a protection for malpractice. That's a real problem. We talk about it a lot, but it hasn't changed. We reward specialized service, which is a good thing. Specialized service when you need it. But we're not particularly rewarding primary care physicians, so what happens? Medical students go into a specialty. So I think we're about to look, and we've experienced in this community a shortage of primary physicians in the past. Finally, we're not strategically reducing cost to increase affordability and to increase access. So in 2012, we have a complex, multi-million-dollar market capable of exceptional care at what has become an unsustainable cost, and in which 1 in 7 Americans work and 1 in 6 are uninsured. What it means in terms of human terms, economical terms, and health terms is next. I'm going to turn the mic over to Susan Mullen, who will introduce our next topic and speakers.
Good evening, everybody. Thank you for coming tonight. Tonight you'll be hearing from healthcare experts about our current healthcare system, what's working and what's not, why we require necessary changes in order to sustain a decent level of care for our citizens. What can be lost in the discussion is what's happening on an individual level to our friends, neighbors, and loved ones in our community right now. We wanted to bring an awareness tonight that the issues presented aren't theoretical and removed from our daily lives, but affect so many around us, even though we may not be aware of it. So many are one paycheck, one layoff, or one illness or injury away from complete financial catastrophe. They may have already lost their homes to foreclosure. Most bankruptcies are due to medical bills. So next we are presenting 2 speakers sharing stories of these friends and neighbors, hardworking folks who may be paying half of their income or using retirement savings just to keep some kind of insurance in place, and others who have fallen into the rabbit hole with no health care insurance as a safety net. Before presenting these speakers, I'd like to share a profile of a couple in their late 50s who have been making very hard choices to hang on to their $550 per month insurance with a $10,000 deductible each and no prescription coverage. Please listen closely to this family's struggle to manage the cost of health insurance and how in the end they had insurance, but they couldn't afford care. Their rabbit hole started in 2005 when the wife was laid off from her job, which carried excellent health benefits. The plan also covered her husband, who had a successful long-term small business. The no-deductible plan offered the usual health care benefits, plus vision, dental, and prescription coverage. After the layoff, the wife joined her husband's business. They were able to stay with the plan through the COBRA extension at a total cost of $600 a month with a small deductible. During the following 3 years, the cost rose by 40%, followed quickly by another 15% increase. The couple kept raising the deductible to keep costs down. By 2010, the deductible was $7,000 a year, at a monthly cost of $500. In order to keep that plan, they were required to pay an additional $250 per month for prescription drug coverage, bringing their total to $750 a month, an exorbitant amount. In 2010, their small business finally had to close as a result of the recession. Meanwhile, they struggled to find any work that paid. They took odd jobs, applied for work everywhere, volunteered in the community, put their house on the market, and started dipping into their savings to live, which included keeping some kind of health insurance in place. They were able to decrease their monthly insurance cost to $400 by accepting a $10,000 deductible each with no prescription coverage. They started cashing in their IRAs. Early this year, they received notice that their insurance went up almost 40% to $550 per month. Despite being insured, they're getting no care, except when they went to the Dungeness Valley Health and Wellness Clinic for treatment for bronchitis. Remember, this insurance doesn't kick in until that individual's deductible of $10,000 a year is reached. Effectively, it's like having no insurance and results in significant delays in needed treatment. Examples for them are a back injury at risk of becoming chronic without a timely diagnosis and treatment, but there is no money in their budget for either the recommended MRI or physical therapy. Medications are limited to generic due to their budget. A previous medication at a cost of $94 perfectly controlled a seizure disorder. The $4 generic causes dizziness. There is now the need to take medication when there is time to lie down rather than fall down. A recommended medical consultation with an endocrinologist isn't affordable, although there is a poorly controlled thyroid problem. Both need new glasses, but can't afford them. It was necessary to take a couple of $1,000s out of savings, which they were grateful to have, to pay for a necessary colonoscopy, even though they had insurance. This couple struggles to be responsible about their health care and protecting their future. This period in their lives has seriously eroded their financial future at a time when they are less than a decade away from retirement. In fact, one party took early Social Security, although that benefit would have been much higher if they just could have waited. Our next presenters are Phil Castell with Castell Insurance and Rose Gibbs, Director of the Dungeness Valley Health and Wellness Clinic, both from SQUIM. I will refer you to your program for their detailed biographies. In 2011, Phil was appointed by Mike Kreidler, our State Insurance Commissioner, to the prestigious Life and Disability Agent Broker Advisory Committee. This committee meets in Olympia throughout the year to provide input to Mr. Kreidler on all things related to health insurance. Phil's been doing business in Washington State since 1987 and in SQUIM for 10 years, and is well positioned to tell us stories of some of his clients, folks who struggle to obtain or keep health care coverage. Phil?
Thank you. I'd like to thank the League of Women Voters for inviting me here tonight. I feel very honoured and pleased to be invited, so thank you very much. I'm originally from England, and so I've had first-hand experience with the National Health Service. And as an insurance agent, I sell an awful lot of health insurance and find it deplorable that as a country we cannot help everyone who needs help. I'll make a couple of quick comments before I'll get into the specific examples that I've been asked to provide today. A lot of the provisions of the Affordable Care Act were front-loaded. This means that while the main benefits may not actually be implemented until 2014, a lot of the benefits were already put in force earlier. This was intended to try and win public support for the Affordable Care Act. Amongst the most notable of these were items like previously most individual major medical programs had a lifetime cap of $1 million. And $1 million sounds like an awful lot of money until you get one of those dread diseases, and then that can disappear pretty quickly. So in 2011, all the individual programs had that lifetime cap removed, which was very good. Other things were preventative care are now covered in full with no co-pays or deductibles first. and also guaranteed issue coverage for children under age 19. So they did a lot of things in advance. So the first situation I'm going to talk about actually occurred in 2010. So this is under the old rules before some of the provisions of the Affordable Care Act were actually implemented. I had a client who had a very comprehensive program. This was actually through one of the Blue Cross Blue Shield organizations. And he called me up one day and said, "Phil, I need to buy more insurance." And his situation was that he was a candidate for receiving a heart transplant. And obviously a heart transplant is a very, very expensive operation. And the reason he needed this is under the old program, the transplants had a $350,000 lifetime max, which for a heart transplant would not even cover a fraction of it. So in order to get him additional coverage over and above the program we already had, is we had to apply for other coverage, which we knew would be declined. And once it'd been declined by another insurance company, that was his ticket to buy a policy from the Washington State Health Insurance Pool, which is premiums approximately 50% higher than an individual program. So we were able to get him the additional coverage that he required, but it ended up that between his Blue Cross Blue Shield program and his Wish-It program, for him alone, he was paying well over $2,000 a month. So that allowed him to get the care that he actually required. Now, if that had happened today, it would still be required to probably go and get the Wish-It program. And the main reason for that is, even though the transplant would be covered because there is now no maximum for the transplant and there's a $2 million per year, the transplant would be covered, but the cost of the antiviral or anti-rejection medications would not be covered. So with the Wish-It program, he would still be able to get coverage for those life-saving medications. So even though we've made a lot of improvements, by the companies cutting back on the prescription drug benefits, people still need a safety net even more than they did before. So he's now paying $2,000 a month or more, but he's got the coverage that he actually needs. So that is a very dramatic example. Unfortunately, there's not too many people in any given population who needs a heart transplant. The next person, this is close to home. This is about my daughter. My daughter is 30 years old and she's an expecting mom, and the baby is going to be due at the end of June. So she called me up, Dad, and said, "Dad, do you know how much it's going to be to add the baby to my health insurance through her work?" And she's got a very good program through her employer in the Seattle area. And to add a newborn baby was going to be $500 a month. When we compared that to an individual program versus the group, the cost would be far significantly less at about $140. True, she would give up some different benefits, but that is one of the compromises she'd have to make, and we'll have to cross that bridge once the baby's born. The last situation I'll bring up is small groups. I've had the 1 minute warning, so I'll ignore that and I'll take 2. Small groups. A lot of times people automatically assume that group insurance will be less costly than individual. It's not. Group insurance generally costs significantly more than individual insurance. One of the main reasons for that is group insurance is guaranteed issue. So if you work for an employer, that coverage will be guaranteed issue regardless of your health. On individual programs, it is health underwritten with a 220 questionnaire to see if you can qualify for it. So we I actually work with a number of different small businesses, and they would like to offer insurance to their employees. But when we look at the cost of group insurance versus the individual insurance, they have to try and find ways to get their employees on an individual program. And as an example, for a small group, an average employee, depending upon the program they went with, the rates would be between $540 to $750 a month for the employee. Similar amounts for the spouses if they were covered. Where if someone were looking at about age 45 to 55, the cost would probably be between $300 and $400 a month for fairly good coverage. So group insurance is great. We don't know what's going to happen with mandates and group insurances when everyone's got to have insurance. It's just going to be very interesting as we progress down this journey. Thank you, Susan.
Thank you, Phil, for highlighting reality for us, our current reality. Next, Rose Gibbs will be speaking. In March 2009, Rose Gibbs, RN, became the clinic director at Dungeness Valley Health and Wellness Clinic after a long and successful career in nursing administration. The 10-year-old clinic is staffed primarily by volunteer healthcare providers and offers care to individuals without access due to being uninsured, underinsured, or unable to get a provider. In 2011, they had over 2,200 annual client visits. 70% of their clients are under age 50, and more than 40% are employed. Many have lost their medical and prescription coverage and provider access. Others found that their essential prescriptions had become financially prohibitive. Rose found that clinic clients are ordinary folks, mostly young adults. They are students, store workers, laborers, caregivers, neighbors, and friends. Many had postponed care, resulting in worsening health, making them too sick to work or hold a job. We've asked Rose to tell us some of those stories to help us understand what is happening to residents in our own community. Rose?
Hi, and good evening, and thank you for having me. I want to talk just real quickly about free clinics. There's over 32 in the state of Washington, and this state is very blessed to have that. It is not that way across the whole United States. Statewide growth in just 2 years went from 45,000 patient visits in 2009 to an estimated 70,000 visits in 2011. And those people are going to free clinics, not to the emergency departments, and not having to pay out of pocket because some of them live by cash. The free clinics serve as a safety net and create access points for some of Washington's most vulnerable populations. In Port Angeles, the Volunteers in Medicine of the Olympics is the free clinic here, and also extremely busy. Free clinics base their services on the needs and resources of the local communities, so we really reflect that. Care is made possible through donations of goods and services. We wouldn't exist without Olympic Medical Center, and Eric Lewis has been phenomenal to help us with that. The space, basic labs, basic x-rays, and that type of services are supported. We wouldn't exist without volunteers. We have over 70 active volunteers. 12 of those are providers. So this is basically free care to the community. And the community donations, which, thank goodness we live in such a giving society up here. It keeps our revenues are really based on the individuals. Many people find themselves seeking care at the free clinic because they had to forego their needed health care, and that was talked about earlier. Some for several years. So when they show up at the clinic there for the first time, they are probably not there for a single problem. It just became too much for them and they finally had to seek help. One of our founding physicians said that patients she sees in the evening clinic are some of the most challenging that she encounters in her career. And nothing is simple, but we try to keep it that way. I wanted to share a couple of stories, and they're not unusual, and you probably have friends that have done this. Recently, we had a 30-year-old woman who had just gotten a job, full-time employment with a good employer, and was so excited about it, but she had to wait 6 months to get her health insurance. Unfortunately, she started having neurological problems, tingling arms. She was getting dizzy. She really was getting compromised in her work. Luckily, one of the people she worked with said, "Oh, have you ever heard of the free clinic? That's where a lot of us go," because they don't have coverage, but she would eventually in her position. She knew things weren't right, and she finally came into the clinic. She was embarrassed. I'm really so sorry, but I just can't afford to go to a doctor." So that's a very typical story. After the examination on this particular person, there was a lot of alarm, and the provider that night said, "We need to get her referred to a higher level of care." Luckily, we have a good connection with Virginia Mason in Seattle and their specialty clinics, and they have an excellent charity care program. She applied for it, and she was able to go there and have diagnostic work done. Her alternative would have been to go to the emergency department, but even after doing that, they would have said, "Follow up with your primary or your provider." She didn't have one. She couldn't afford to go to the emergency department, and she was terrified of getting a charge for a CT scan or an MRI. Those are extremely expensive to diagnose her problem. So for her to be able to go over to Seattle through our referral and connections and getting her financial assistance, she was able to continue with her new job and her management career in the hospitality industry. She wouldn't have been able to do that without somebody as a safety net, and that's what we see ourselves as. Another patient we saw is a mid-50s gentleman. He woke up at Olympic Medical Center. He didn't know what happened, but he was taken by ambulance, and he woke up there. And he was told, "Sir, you have diabetes and you need to be on insulin." In the hospital, he received minimal education due to the time frame that he was there, and he was discharged. Of course, he didn't remember any of his education because he was in a daze about his health. He was totally blown away. His comprehension was compromised. And most of us are like that in stress. He came to this area just to visit his sister because he had gotten laid off from his job in another state. His sister was terrified because, yeah, he could stay with her, but she can't afford his medical needs, particularly with the new diagnosis of diabetes. And she knew he needed help desperately. They did some search, and the hospital recommended that since they were in SQUIM, that they contact us. He came to the evening clinic, had his discharge papers from the hospital. He had a very sad story. He had no income. He couldn't afford his insulin. Insulin can be $150 to $750 a month, depending upon how much you have to take. He had no income. He just didn't know what to do. He had no equipment to even test his blood glucose with. And to top it off, he was terrified of needles. Now, if you're a diabetic, that's a real problem. Luckily, overall, about 3.5 years ago, the free clinic that I work in started a chronic care program run by a nurse practitioner, managed by that. And we got him into that immediately, within 1 or 2 days. Through that chronic health care program, he was able to be examined, get blood work done, and we started that trek of doing high education. He met with our diabetes educator. We connected him with our prescription assistance program, and he's able to get his insulin. And because he's afraid of needles, we were able to get him insulin that comes in a little pen. So you can't see it, you don't have to draw it up, you just stick it in. There is a needle, but you don't see it. You know, it's kind of hidden. And you don't have that draw it up and, oh, find a spot kind of thing. So that worked for him. It was kind of like blind insulin. He would never have been able to pay for that otherwise. But he had intense education through every nurse and every person he met in the clinic. And for probably 6 weeks, we saw him a minimum of once a week. And it really needed to be. He was so terrified, he just really couldn't retain what you taught him. But I have to say that through this, he has been able to learn how to eat properly, understand exercise importance, what his blood sugar means, how to monitor that. And he has not had to return to the hospital. He told me a few weeks ago that we saved his life. In many ways, I think that's a true statement. Another common patient that we see in this community, and Vimo sees a lot of them as well, someone who had been under health care, this is a young lady who had an accident. She's 22 years old. Had a car accident when she was, I can't talk that fast. And she was put on pain medication for her back pain. But she never had her back pain managed. She was just, oh, you're young, you'll get better. Here, take this, you'll feel better. She realized she was addicted to that pain medication when she came to our clinic. She no longer had health care. She had nobody to cover her or provide her. And through our clinic, we really have to limit the use of controlled substances. That's a state law. And it's very, very tough and it requires a lot of documentation. One of our providers said, I will take her on, and he did frequent visits with her and started tuning down her medication, used other medications that were not narcotic, and we also got her into counseling. She has a young child. She works part-time. If nobody did that for her, she would probably be on the streets trying to buy drugs. And this is a terrible, terrible thing for people to have to go through. In this community, one of the things that you'll hear, there is not much available for pain management for chronic pain. And there's really not much out there. And if you don't have insurance or a lot of money, you're probably not going to be able to get it. The last person I was going to tell you about, but I have to talk real fast too. He got 2 minutes. This man had foregone going to health care because he couldn't afford it. He knew he couldn't afford it, but then he saw his life going down the tubes. He was so weak, he couldn't get up in the morning. He was having problems. He came in and saw us in the evening. He heard about our clinic. The provider said his condition was very serious. He documented his findings. We got financial assistance paperwork filled out from the medical center. We had some expensive diagnostic tests done. And from there, we had to make kind of urgent referrals to 2 specialists. And one had ended up being through the cancer center, through oncology. The immediate treatment made a huge difference. He went through chemotherapy, and the Olympic Medical Center helped with that, and radiation therapy. But he still had his other underlying health issues, so we were his health home for those things. When the specialist had done his best, we were still the people who were going to keep him healthy with his heart and everything else going on. But if he wouldn't have come in, he probably would have ended up in the emergency department, and he would have had treatment, but the delay is tremendous. Though healthcare reform may have many positive effects on the healthcare system, and certainly it needs reform, I have no doubt in my mind, those effects will not be immediate. When I took this job 3 years ago, they said, oh, well, we probably won't need to have you too long because, Obamacare is going to go through or healthcare reform is going to happen. And I said, I'm not going to hold my breath on that one. It is so complex, and that's what this whole forum is about. So it's an amazing thing, and I'm amazed and privileged because I'm in a position where anybody coming through our door, we help. And that feels wonderful as a safety net for this community. Thank you.
Thank you, Rose, and thank you, Phil, for giving us a picture of what's happening in our community to our friends and neighbors. And now I'm going to return you to Bertha.
Yes, and imagine what would have happened to those people without the clinic and their care had been delayed. Thank you very much. Now let's turn our attention to our own community. Eric Lewis, a former colleague of mine, but better known as a hardworking CEO of Olympic Medical Center. Eric has been with OMC for the past 14 years, first as the Chief Financial Officer until 2006 when he took on the role of CEO. Eric is going to speak about the threats and vulnerabilities with our own community and its ability to provide services.
Well, good evening, and I want to thank the League for putting on this series of 4 forums, because I think the healthcare delivery system here in Clallam County is on an unsustainable track. From an individual standpoint in businesses, it's too expensive and there's not enough access. And from Olympic Medical Center's perspective and private practice physicians, Medicare and Medicaid reimbursement is simply too low to sustain us. So tonight, the things I want to talk about first is a little bit about Olympic Medical Center and how we're reimbursed and the challenges that they present, a little bit about the Affordable Care Act, and then talk about some needed reforms for our local delivery system. One thing about Olympic Medical Center that I want to point out is we're a very unique hospital. There's 96 hospitals across the state, but there's only 4 hospitals like Olympic Medical Center. And that's a large rural hospital that is a sole community hospital. Most rural hospitals are what's called critical access. They're hospitals with 25 beds or less, and they're paid 101% of cost by Medicare, Medicaid. Olympic Medical Center with 80 beds is very unique, and there's only, like I said, there's only 3 other hospitals like us, and we face some very unique pressures in that we have a lot of Medicare, Medicaid, and we're paid a lot lower than costs. And I think the other thing is I think having more local healthcare services really does help improve our local economy, and we want to provide as many local services as possible because patients, the cost of traveling and the challenge of traveling to Seattle or out of area is significant. The first thing that's unique about Olympic Medical Center is our payer mix. Outside of critical access hospitals, which are paid costs, Olympic Medical Center has the highest government payer percentage of any hospital in the state. 77% of our patients are paid for by a government program. Now, the vast majority of them are Medicare, over 56%. Medicaid's about 12, other government is about 9. So 77% of our patients are paid for by government programs. So what happens in Olympia and DC really does affect us. And uninsured's about 3.7%, and commercial insurance is only 19%. One of the biggest challenges we face locally and across this country is uncompensated care. There are over 10,000 residents in Clallam County that do not have any insurance. That is a significant challenge. Last year, Olympic Medical Center provided about $9.3 million of uncompensated care, and it's been growing rather dramatically over the last 5 years. And if we really look at the challenge is how does Olympic Medical Center pay for this? Now, our public is very generous, and we have a tax levy that's about $3.6 million. That goes to pay for this. But unfortunately, we have to charge our commercial insurance patients more money to help cover this. We don't have a printing press in our basement. We have to fund it some way, and it's really, my concern is, without reform, where does this go? And it could be a major challenge for Olympic Medical Center's future. Turning to Medicaid, now Medicaid is for people with low income, and it's 50% funded by the state and 50% funded by the federal government. The biggest challenge we face is Medicaid reimbursement. It is significantly below our costs. We have to file a cost report every year. We haven't filed the 2011 cost report, but it's stayed pretty much the same. In 2010, we were paid about $8 million. For the cost of that care was over $15 million. And at 53% of costs, Medicaid is just a big challenge for Olympic Medical Center and our medical staff. The state budget challenges in the coming years really are going to put a lot of pressure under Medicaid. And one thing about the Affordable Care Act is it really substantially expands Medicaid. Medicaid is currently at 100% of the federal poverty level, and it's going to go up to 133% of the federal poverty level. So I think Olympic Medical Center could face significantly more Medicaid, and you can see it pays us well below costs. Medicare is a huge program for Olympic Medical Center. I think the biggest thing about Medicare is the federal budget and the challenges there. The federal government has run about $1.3 trillion deficits the last 3 years. The baby boomers, there's about 78 million baby boomers, and about 300,000 baby boomers are retiring each month or moving on to Medicare. And Medicare is going to face huge pressure from the baby boomers in the coming decade. And I think, in order to fund access, which was really needed, the one thing they did, they cut about $500 billion over 10 years out of Medicare. Now, because Olympic Medical Center is one of the highest Medicare hospitals in the state, this really disproportionately affects us. And by cutting Medicare, it's just going to make it challenging for us to balance our budget. Medicare is paid on a prospective payment system, or at least Olympic Medical Center is, and most hospitals are. And if you look at Olympic Medical Center's reimbursement on a per person, per month basis or per year basis, Olympic Medical Center got the distinction of Medicare saying that we're in the bottom 10% of all reimbursed counties in the whole country. So we not only have a lot of Medicare, we have low reimbursement, and we're facing more cuts in Medicare. I think the single biggest challenge when it comes to reimbursement is physician reimbursement from government payers. Reimbursement for Medicare and Medicaid is significantly too low to sustain physician practices. At the same time, physician shortages have been driving physician compensation higher. And I think if you look at reimbursement from various programs, a basic level 3, which is the basic office visit, a commercial insurance company might pay $83. Now, Medicare will pay $70.55, and this is for a patient that is more complex and probably takes more time than the commercial insurance patient. But Medicaid is really low at $22.93. Now, there are various ways that Medicare and Medicaid will pay more to physician practices, such as rural health clinics and hospital-based clinics and tribal clinics. But some of those are being threatened with reimbursement reductions. But I think a healthcare system that doesn't reimburse physicians adequately will cause huge access problems and is not sustainable. You may have insurance, but if you have no physician to be able to go see, no providers to take care of you, it's just not going to work. So this is a major thing that needs to be reformed in the coming years. Now, if we look at the Affordable Care Act, we talked a little bit about the health insurance reform, which has happened. The big thing it does is it improves access for our citizens. It's going to cover about 30 million people in the United States is one of its goals. I think the last two, as far as improving outcomes and controlling costs, it falls short, and we need more reform in these areas. I think any system, the healthcare system we have right now does not control costs well, but we're going to put 30 million more people into it. So I think cost control and really examining how we can improve outcomes. And I think one of the biggest challenges we face is in our current healthcare system, we wait until people are sick and then spend a lot of money. I think if we can move those healthcare dollars earlier in the disease process, we could have better outcomes and control costs better. If we look at how the Affordable Care Act is going to affect Olympic Medical Center, I'm just going to touch on a few things, but I think one big way is it is going to reduce our uncompensated care, and it will provide significant access for our citizens. There should be, if you take the national averages and goals, about 6,000 uninsured Clallam County residents would be able to somehow get insurance either through Medicaid or through the health insurance exchange or through their employer or through subsidies that they're able to get from the federal government. So it'll create maybe 6,000 more people that are insured. That will reduce our uninsured dramatically and I think improve access significantly. The big challenge we face is, of course, the Medicare cuts we know are coming. Medicare cut roughly 1% a year for the next decade. They call it a productivity cut, but Olympic Medical Center faces $26 million of cuts from 2010 to 2020. 2019 in Medicare to help fund this access. Now you notice the cuts are in place starting now, but the access doesn't happen until 2014. One of the concerns is additional cuts to Medicare. There's already a 2% sequestration cut that's going to happen on January of 13, and both parties are talking about more cuts to Medicare. And I think because Olympic Medical Center is a large rural hospital with so much Medicare, we're already at the bottom 10%. The way Medicare does cuts is they cut 2% across everybody. So when you're at the bottom of reimbursement, you get cut 2%, it just hurts that much more. We will experience more Medicaid patients. The big challenge there is we don't know what Medicaid is going to pay us. That's a state program. The state determines how the program works. The federal government funds roughly half of it. Now for the expansion of Medicaid, the federal government is going to fund that for a while, but eventually it's going to become a state burden. And I think certainly we are starting to work on delivery system reforms. I think the biggest thing we've done is we've affiliated with Swedish Medical Center. We're still independent entities. It's a contractual relationship, but it's a long-term 20-year partnership. We're going to be working together on clinical services and buying groups and electronic medical records. So I think that's a huge thing that will really change the way Olympic Medical Center functions. I think the threats to Olympic Medical Center survival is mainly how we're reimbursed. Various hospitals over the years have shut down at Olympic in Washington State. Many hospitals have had to merge with other delivery systems. And I think if Medicare or Medicaid doesn't pay us adequately over time, when we compare it to our costs, it will probably force us to seek to merge with some larger entity. Uncompensated care without reform, I think, could be beyond what we can fund. The good news is healthcare reform should address that, or most of that. And if reimbursement is so low that Olympic Medical Center cannot fund our capital needs, primarily medical equipment, it just will be impossible for us to stay in business over time. So we do face big challenges. I think healthcare is local, and I think local ownership and local control have their big advantages. And if we can maintain local control, I think over the coming 10, 20 years, we'll have more services local, and it'll better meet our community's needs. Needed reforms, I think we need medical liability reform. We need pharmaceutical purchasing reform. Right now, if we could access a program the federal government has called 340B, Olympic Medical Center could purchase our drugs for about $2 million less annually. And Jefferson Healthcare and Forks Community Hospital have access to this program, but because we're a large rural hospital, we're not eligible. But I think that should be reformed. That would save Olympic Medical Center $2 million, save our patients money, not cost the government any money. It allows us to purchase medications at the federal government rate. Geographic variation needs to be addressed. Medicare reimbursement is not even across the country. There's places in Florida that get paid twice as much compared to us, and that needs to be addressed, I think, for us to survive over time. And I think we have to change the delivery system from fee-for-service to more outcome-based, perhaps per person per month, and with a focus on chronic disease management. One of the big changes that's happening is both the federal government and the state government are looking at how to change the delivery system away from fee-for-service. And there's something called accountable care organizations, which is really what we used to call HMOs back in the 1990s. And that's really changing reimbursement to per person per month rather than fee-for-service. And I think, like I said, Medicare and Medicaid are really looking at this, and I think it's going to be a change that will happen over time. And ultimately, the local healthcare insurance or the local healthcare insurance provider will be, like Olympic Medical Center, could provide insurance for our local citizens and our local companies. And it would really change the way we provide care. Although we face huge challenges with Medicare, Medicaid reimbursement being so low, and society really having trouble funding health care, I think there's good reasons for optimism. Olympic Medical Center, I think the good news is that we definitely need a hospital here and we need a lot of health care. There's 70,000 people, 16,000 people in Clallam County are on Medicare. There's good demand for our services. I think we just have to figure out how to make our costs and our reimbursement equalize. I think our elected officials really want the local healthcare system to succeed, both at the state and federal level, and we're trying to work with them to reform the systems to make sure it stays viable. I think the Swedish Medical Center affiliation, Swedish is now merged with Providence, so we're affiliated with Swedish Providence. I think it's going to be a very good partner for us over time, and we'll get some of the benefits of being part of a system, but we'll still be an independent, locally owned hospital. The biggest strength of Olympic Medical Center is our medical staff. We have great physicians and other caregivers. We have great RNs, technicians, and support staff. I think with such great employees, that really gives us a big advantage as we head into these challenging times. And I think delivery system changes are possible and will happen. There's no question in my mind that Olympic Medical Center is going to change with the times and work very hard to stay viable and improve what we do for our patients and our community. So as we look forward, I think Olympic Medical Center is embracing reform and trying to be ready for it. We're working on something called the Triple Aim, which really hopes to improve each patient's individual experience on access and service and quality care, work to improve outcomes for the whole population, and work to control costs. And I think if we work on all three of those, we can have a delivery system that really helps meet our patients' needs. And really, Olympic Medical Center's survival really depends on reform that helps us control costs and results in reasonable payments for Medicare, Medicaid so we can take care of our patients. So with that, I think I'm actually done on time.
Excellent presentation. To be optimistic and talk about survival at the same time is pretty tricky, I think. Oh, I'm not going to repeat that. Okay, thank you, Eric. We thought it important to include a presentation on the impact of the healthcare system on our economy. After all, that is what the discourse is about nowadays. Costs, Medicare, free markets are running conversation topics. We thought we needed to understand that better. It wasn't easy to find somebody willing to speak. I thought it would be. I was surprised to learn that economists hesitated to talk about healthcare economy until I realized it was a little bit like asking a neurosurgeon to talk about orthopedic implants. Economists are specialists as well. Well, with a lot of help, we were fortunate enough to find Dr. Frederick Chin. Dr. Chin is an associate professor at the University of Washington School of Medicine and chief of family services at Harborview Medical Center. He holds a master's in public health and has an impressive background of research in a variety of healthcare issues. He holds an MPH. I find doctors with MPHs to be fearless and willing to talk about economics. Dr. Chin is going to speak to us about national economic impact and has kindly added national outcomes to his presentation. Welcome, Dr. Chin, to our community.
Thank you, Bertha. I didn't know you'd gone through all the health economists in town first. Actually, they have a really tough job. Health economists, you know, you're talking about a sector of the economy that has uncontrollable costs. You actually can't figure out what the costs are. You can't figure out what the prices are. You have no way to really control any of them, and then you're supposed to be an economist and explain it all. So that's why I'm not at all surprised it's hard to find somebody to come talk about it. I'm really pleased to be here. One of the jobs I have is I teach health policy and public health to the medical students at the University of Washington. And this is a real treat, talking to actually a live audience and not a whole bunch of laptops and cell phones. About a third of our class doesn't even come to class. They actually just watch me at 3 times speed at home, because all of our lectures are podcasted. So anyway, live audience is very exciting for me. I also really appreciate the forum so far and the attention on people and on personal stories, because that is actually at the heart of healthcare, and it's the heart of what we do in healthcare. I saw patients this morning in our family medicine clinic at Harborview. It is important to remember. I'm going to show you a bunch of graphs. We're going to talk big picture, national economy, international stuff, but it is always important to remember that at the heart of it, the core of it, is one person and one person. One person sick and in need, one person trying to help. And that the stories and the way that you've put this personal face on it is critical. So I really appreciate that introduction as well. I do want to talk a little bit more about how much healthcare costs. I want to talk a little bit more about the history of how we got here, and then, as you heard, the impact on the economy and health in general. This is pretty much, of all the graphs I'm going to show you, this is the only one that you need to know, really, because it tells the story of American healthcare, and it is the continued growth in spending on healthcare. The graph starts in 1960 there. You see along the bottom in the years, but you also see the percentage of the gross domestic product that we spend on healthcare. And indeed, we are currently, this ends in 2008, but we are now into the 17 and 18% of gross domestic product. So we spend a lot of money. And the y-axis, that's dollars in billions. So that's like $2.5 trillion we're talking about. This is real money, even for Americans and for Congress. It's real money, and it's a really big part of our economy. And in fact, what this shows you is that in the U.S., us spending 16-17% of our GDP on healthcare, it dwarfs what we spend on other things like housing, or food, or national defense, motor vehicle parts. You know, it is the largest sort of single segment of our GDP that we spend. And we'll talk more about international comparisons later, but let's not forget we actually spend far more than every other country on the planet on healthcare, and this is part of our great dilemma. This is one of these things that everyone agrees on, whether you're liberal or conservative, Republican, Democrat. There's no doubt that we are number one in healthcare spending on the planet. So what do we actually spend it on, or so where does that money come from? We've seen a little bit of this already. You've seen the Olympic Medical Center breakdown of this. But in this country in general, about a third to sort of 45% comes from private and commercial health insurance, and then almost half of that, the left-hand side of that pie, almost half of the spending comes from government sources. So that's Medicare, Medicaid, and then other state and local sources. So we are in a situation where we do have a public payer for almost half of our healthcare spending already. Bertha touched a little bit on the history of this, going back to World War II, the wage freeze, the reason that we have an employer-based insurance system. It was because of the wage freeze and because of the tax deductibility of health insurance benefits that was given to employers. What that really did, though, is it tied us to a health insurance-based system. And what health insurance, insurance has a lot of upsides, but one of the things that it also does is it distorts the market. So as much as we like to talk about a market-based healthcare system, we have one that's distorted because you have insurance in between. You're not paying, it's not chickens and eggs for healthcare, it's an insurance card for healthcare. The costs are managed by an intermediary. And so it has for a long time insulated patients, consumers from healthcare prices and costs. Of course, after you had an employer-based health insurance system, we had to fix the problem of how are you going to insure older folks who aren't working anymore, and how are you going to insure the poor and indigent, and that was the story behind Medicare and Medicaid in 1965. So currently, this is our system. We still have almost half of our system is employer-based insurance, and then Medicare and Medicaid, and then we continue to have that troublesome group of uninsured. 50 million people, 17%. Who are the uninsured? Let me spend a couple minutes talking about what it means to be uninsured. We've heard the personal stories. These are national data. The pie chart on the left shows that 60% of uninsured families have one or more full-time workers in them, so they're not all unemployed folks. They tend to be lower income. You see that in the middle slide shows that 40% of them are under the federal poverty level, but another 40% are between 1 and 2.5 times the federal poverty level. And then the age distribution, they do tend to be younger folks. 40% are 19 to 35, another third are between 35 and 55. This is the uninsurance sort of map for our state, and Clallam is definitely represented there. And this is what it means from a health standpoint to be uninsured. If you're uninsured, that's the blue bars. If you're uninsured, over half of folks who are uninsured don't have a usual source of care. 40% don't get preventive care. A quarter went without needing care, without getting care because of costs. A quarter couldn't afford prescription drugs. So being without insurance has real consequences. It also has not just health, but financial consequences. And this shows that 20 to 22% of them have either used up all or most of their savings if you're uninsured, or are unable to pay for your basic necessities. Let me shift and talk about even for those who are lucky enough to have employer-sponsored health insurance, the story is changing and changing fairly quickly for them too. This graph going upwards is the increase in the price and the of health insurance premiums for workers, and that's a pretty steady increase in the line. And in fact, what you see from this period from '99 to 2011 is 160% increase in health insurance premiums, an 160% increase in workers' contributions to your premiums, and far outstripping your growth in earnings and in inflation. This is the economic impact. It is an impact on workers, employees. It is obvious. It is also an impact on the companies who hire them and employ them. So this is the same thing. I was showing you the actual. We heard about this a little bit already, but the growth in the dollar amount. And for employers, as I just mentioned, the costs have gone up for employers too. So the costs of premiums, the costs of the employer's share for health insurance has also gone up, and that is also in billions of US dollars and the average increase per decade. So that is why Chrysler and GM are no longer competitive, because of the healthcare benefit they have to provide to their employees and retirees. right? This is the story of the impact on the U.S. economy, on your local businesses, on our major corporations. This is why when I teach the medical students and they say, this doesn't feel like it's just a story about doctors and patients anymore. It feels like it's a story of negotiations between employers and insurers and hospitals, and that's exactly what it is, because it has become such a big part of the story. And every year there's a student who says, I bet Weyerhaeuser would rather just plant trees than deal with health insurance. And that's exactly right. And that's the dilemma we found ourselves in, because we are tied to the employer-based insurance system, and the costs have been continuing to rise for them. What do we get for all that money that we spend? Well, that's another troublesome part of our story, which is that the quality of care in this country is quite variable. We all like to think, I don't know what that was at the top. Okay. We're gonna, that was good. We actually already saw the quality rankings, which were the WHO rankings, which ranked the United States somewhere around number 37 in terms of quality. That's quality based on access to care as well as other measures. And one of the other interesting findings about this is this is also one of these research stories that ties into the quality story in the U.S. Why is there so much variation this is just geographic variation in Medicare spending per beneficiary. And what we find is this is not just where all the old folks live. This is actually the kind of variation that you find even from one county to one county, or one town to the neighboring town. This is the story that Atul Gawande wrote about in the New Yorker about McAllen, Texas. Because we haven't had standards, and because we have such a fragmented healthcare system, the incentives and the variability of healthcare delivery is vast in this country, and it really gets to sort of concerning observations about what we're getting for that dollar. So why are we getting so much more variability in one town versus another? We've already talked about the main elements of the Affordable Care Act and how it begins to address some of these problems. It starts with a series of health insurance system reforms, the creation of state-based health insurance exchanges so more people can buy insurance. It is predicated in part on the idea of an individual mandate. That is how, Phil will tell you, that is how insurance works. The larger the pool, that's the way you manage a population of insureds. That's the way you keep costs down. If the pool is only the sickest people, then that is going to be a very expensive pool of insurance. And that's why there's an individual mandate in the ACA. And then the big question around how we're actually going to pay for it. What the government calls savings in Medicare and Medicaid, Eric will call decreased payments and reimbursement, and so it's a matter of perspective for sure. But there is built into elements of the ACA reductions in Medicare payments, savings presumably from better care coordination, better care delivery, and we should also be honest. There is actually quite a bit of waste, fraud, and abuse in this spending. $2.5 trillion. It's not all going to the most efficient practices, and so that's the quote low-hanging fruit. It's just hard to figure out when there's 8 people standing around your mother's bed, which one of those 8 people is not really necessary, right? And because there are 8 people standing around the bed, it is, as part of the U.S. economy, just a huge part of labor. We're one of the good things really about healthcare is that it is actually about people as well, not just sort of the spiritual importance of people, but the fact that it is labor intensive, and it is the part of the economy that has sort of kept us going through this recession has been healthcare employment, because it is labor intensive work. You cannot outsource bedpan cleaning. right? There has to be somebody who's there. So what lies ahead? The healthcare costs do continue to rise. We have the issue of uninsured, of course, quality concerns, which we've touched on, and the demographic reality of this country, of the aging of the baby boomer. And we are right at that inflection point, 2012, where the number of folks eligible for Medicare is rising at a much faster rate. Let me switch gears a little bit and just talk about the second question that I always get after sort of help me understand the cost is, well, how do other countries do it? And I, like many things in healthcare, it's actually not it's not as easy as you would think. So again, this is comparisons with other OECD countries on how much you spend either per capita, per person on healthcare, or your total healthcare. And again, USA #1 on that list, on both graphs. So that's the brown line. But it's not quite so easy when you actually dig into it about what's the reason, why are we so much more expensive, and again, what are we getting for it? So life expectancy, which Bertha had mentioned. Japan has the highest life expectancy in the world. The United States is, actually help me find it, it's sort of right below the red bar, the OECD, sort of below, between Chile and the Czech Republic. So I guess we're not buying a ton of life expectancy for the $2.5 trillion, but is it because we have more physicians? Actually, it's not. We actually are also below the OECD average between Slovenia and, interestingly, Japan, sort of in the lower third there. Greece actually has the most physicians per capita, and you wonder how much of that has led to their where they currently are in their economic piece. So it's not actually that we have too many doctors. Or hospital beds. Germany actually has more hospital beds per 1,000 population than the other OECD countries. And the average length of stay in the hospital, that doesn't explain it either. US, again, is down on the bottom here at 4.9. That's days in the hospital. Look at Japan, by the way, where the average length of stay is actually somewhere between 19 and 25 days in the hospital. The number of we heard about technology a little bit. Is it because we actually have more MRIs and CTs as markers of our high technology? Again, actually, Japan actually has more MRIs and CTs per capita. US is definitely up there near the top. The graph on the left is MRI machines. On the right is CAT scanners. But it's not that clear cut as we would think. And then this is sort of comparing us with the percentage of your total population who actually has health insurance. And so that's always a little bit disturbing, yes. Just to be fair, there is the issue of wait times in countries like Canada and the UK, and so that we put that here. These bars are over time, and actually you've seen the UK and Canada both improve their wait times. And so the US does tend to have better wait times for elective surgeries, although no better than Netherlands, Switzerland, Germany, or France. So for me, it actually, and this is the health economist part of me that comes out, it actually does come down to the prices for me, which is one of the hard things to understand about healthcare. Why is it really so expensive in this country, and why is it so much more expensive in our country? But this is a standardized pricing that compares surgical procedures amongst countries, and you see that in general, US pricing is about double for most of these procedures. In fact, this is actually a well-cited article in Health Affairs that came out last year that talks about it is actually the prices. And it's probably not just the prices, but it's one of the important elements in international comparisons to keep in mind. And then finally, what did we learn from the experience with health reform in 2010? We learned that employer-based health insurance is not going away, actually. Kudos to the League for supporting single payer, but that was one of the first things off the table in the discussion in 2010. So we have an employer-based health insurance. We have had one for a long time. There's nothing in the ACA that changes that. There are clearly a lot of people who are worried about healthcare and the impact on the economy, but then there are also fewer people who are willing to change or give up what they currently have. And it does look like we may be able to expand coverage, but the question is going to be at what cost and how are we going to manage that going forward. So I'll leave you with just a couple thoughts. One you've already heard, which is that healthcare is about labor and it's about people, and it does require a lot of people, and that's part of the cost story, but not the entire part of it. The other thing is, I hate to leave this as a message, but it's true, and that's that our healthcare system is complicated. And I say that mainly for you to be wary and guard against oversimplification. The people who tell you it's just because we have more MRI machines are wrong. Or the people that tell you it's just because of the medical malpractice system are wrong. It's never that simple. We've had 50 years of showing that it's not that simple. And so I want you to be aware and wary of oversimplifying the problem. And at the end of the day, I think it'll probably be like what Winston Churchill said, which is, Americans will always do the right thing, but only after they've tried everything else. So thank you very much.
Well, thank you, Dr. Chen. A lot of information, a lot to think about. I learned a lot. I learn every day about this and how much there is to know before we can provide some direction to our elected officials.